Chorea. Letter of Referral. Dear Dr. Re. MRS Ethel Lane, aged 72 years. I would be grateful for your urgent review of this woman who is known to you with Parkinson's disease. She has started to develop writhing and jerky spontaneous movements over the past few weeks, which have become very disabling and tiring. I have been gradually increasing her Parkinsonian medications since you commenced them 5 years ago. Please could you advise as to the cause of these movements and their management? Yours sincerely. Introduction. Chorea is a continuous or intermittent flow of irregular, jerky, and sometimes explosive movements that move from one part of the body to another. Each movement is brief and often appears as a fragment of what might have been a normal movement. Causes of chorea are shown in Table 6, the commonest being in the context of chronic L-DOPA treatment in Parkinson's disease, clearly the presumptive diagnosis in this case, or as part of Huntington's disease. Table 6 Causes of chorea. Common. Levodopa-induced dyskinesias. Huntington's disease. Basal ganglia strokes. Uncommon. Systemic lupus erythematosus, SLE, and primary antiphospholipid syndrome. Carbon monoxide poisoning. Pregnancy. Sydenham's chorea, post-streptococcal. Genetic, neuroacanthocytosis, Wilson's disease, benign hereditary chorea. Hyperthyroidism. Polycythemia rubra vera. Drugs, especially neuroleptics and oral contraceptives. Cerebral palsy. Senile chorea. History of the presenting problem. Which parts of the body are affected? Chorea often affects movement and speech and can be extremely disabling for some patients. A useful trick in routine practice, but not in PACEs, that highlights any minor degree of chorea is to ask the patient to perform a repetitive task or to walk. When did the condition begin? Patients who present with chorea as young adults often have a different cause from that in the elderly, although there is significant overlap. A young adult with chorea should raise suspicions of Huntington's disease, Wilson's disease, and other rare genetic disorders. Young adults are also more likely to present with post-Sydenham's chorea, especially in women who are pregnant or taking the oral contraceptive pill. Antiphospholipid syndrome, SLE, and thyrotoxicosis are also commoner in young adults. The elderly patient with chorea often has a history of at least 2 years treatment with L-DOPA, usually for Parkinson's disease, as in this case. How fast was the onset? If the onset is acute, then the commonest cause of chorea in the elderly is in association with a stroke in the basal ganglia, which often affects the contralateral side of the body. When the stroke involves the contralateral subthalamic nucleus, patients develop severe chorea or hemibolismus. NB. Senile chorea is a controversial diagnosis where no cause can be found in the elderly. However, many of these patients probably have chorea that is drug-induced or associated with basal ganglia strokes, and some have been found to have late-onset Huntington's disease. Other relevant history. The most important aspects of the history to elucidate in a patient with chorea are: a full drug history, family history, vascular risk factors. Relatives of the patient may be helpful in clarifying these events. Plan for investigation and management. Investigations. Blood tests should include FBC, particularly noting the hematocrit, fresh blood film for acanthocytes. Look in 3 samples for cells with many thorn-like projections from the surface membrane in an extremely rare condition called amyotrophic chorea acanthocytosis, clotting, prolonged activated partial thromboplastin time in lupus anticoagulant, and erythrocyte sedimentation rate. urea and electrolytes, glucose, liver function test, thyroid function test, copper, ceruloplasmin, antinuclear antibody, anticardiolipin antibodies, and anti-streptolysin O titers. Imaging. CT scans may demonstrate multiple infarcts in the elderly or atrophy of the caudate nucleus in those with Huntington's disease. MRI is more sensitive at detecting subcortical infarcts and caudate nucleus atrophy in Huntington's disease. Genetic tests for Huntington's disease. Management. Any underlying disorder, e.g. Wilson's disease, should be treated. Some forms of chorea are self-limiting, e.g. Sydenham's and post-stroke. Some patients with Huntington's disease do not find their chorea troublesome. If the patient becomes significantly symptomatic, then pharmacological therapies to reduce chorea are available, including tetrabenazine, although this can cause depression, and neuroleptics, e.g. risperidone, sulpiride, and olanzapine. Patients with Parkinson's disease should have a thorough drug and on-off history taken. Some patients can convert part of their L-DOPA therapy to smaller doses in conjunction with a dopamine agonist. In older patients who are sensitive to the neuropsychiatric side effects of agonists, total L-DOPA dose reduction is often required, resulting in poor mobility. NB. Genetic causes of chorea. The pattern of inheritance may help, although the family history, especially in patients with Huntington's disease, may be missing or incomplete because of a high incidence of early mortality in affected relatives. Further discussion. Genetic testing for Huntington's disease is now readily available in genetic reference laboratories. This needs to be undertaken sensitively and with the help of trained geneticists. Pre-symptomatic testing is a difficult issue and many patients at risk of developing Huntington's disease choose not to be tested.